You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode will cover non-compaction cardiomyopathies, Takotsubo or stress cardiomyopathy, and myocarditis. Let's start with non-compaction cardiomyopathy. Non-compaction cardiomyopathy will have a two-layered myocardium within a thin compacted epicardial and thick non-compacted endocardial layer. There will be a prominent network of trabeculations in the non-compacted layer. Diagnosis involves a ratio of non-compacted to compacted myocardium of more than 2:1 at end systole in the peristernal short axis view on echo. A trabeculated LV mass of more than 20% of global LV mass, presence of deep recesses that fill with blood from the LV cavity as demonstrated by color Doppler or contrast agent in the non-compacted layer, but that do not communicate with the coronary circulation because you want to distinguish recesses from sinusoids, and segmental distribution of non-compacted segments, most often in the apex or midventricular inferior and lateral walls. Note that cardiac MRI criteria are slightly different and uses a ratio of non-compacted to compacted layers of 2.3 diastole rather than systole, whereas echo criteria uses a ratio of non-compacted to compacted myocardium of more than 2:1 at end systole. Non-compaction cardiomyopathy patients are at increased risk of sudden cardiac death, need for advanced cardiac therapies, and ischemic stroke, especially if fibrosis is present, as indicated by late gadolinium enhancement on cardiac MRI. This prognostic sign is true in both LV non-compaction patients with reduced ejection fraction and preserved ejection fraction. Delayed enhancement of the left ventricle is associated with increased risk for adverse events. Other risk factors include thin myocardium, apical aneurysm, and LV dilation. However, these findings alone are not likely to prompt implantable cardioverter defibrillator placement, and further assessment of arrhythmia burden is needed. Right ventricular insertion point delayed enhancement can be seen in elite athletes and is not associated with increased risk of LVNC. Aside from its role in diagnosis, the degree of non-compaction does not hold prognostic implications, and neither does the trabeculated mass percentage. 1/3 of LV non-compaction patients have non-sustained ventricular tachycardia, and 1/10 of them have atrial fibrillation. If normal ejection fraction in non-compaction, then use HCM criteria to determine sudden cardiac death risk and decision to place an ICD. If low LVEF in non-compaction, use a combination of dilated cardiomyopathy and hypertrophic cardiomyopathy criteria to determine sudden cardiac death risk and decision to place an ICD. The indication is stronger if there is non-sustained VT, EF less than 35%, a syncopal episode, or family history. Can athletes with LV non-compaction participate in competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, until more clinical information is available, participation in competitive sports may be considered for asymptomatic patients with a diagnosis of LV non-compaction and normal systolic function without important ventricular tachyarrhythmias on ambulatory monitoring or exercise testing, and specifically with no prior history of unexplained syncope, Class 2B. On the other hand, athletes with an unequivocal diagnosis of LV non-compaction and impaired systolic function or important atrial and or ventricular tachyarrhythmias on ambulatory monitoring or exercise testing, or with a history of syncope, should not participate in competitive sports, with the possible exception of low-intensity Class 1A sports, at least until more clinical information is available. That's Class 3. Now we'll move on to Takotsubo cardiomyopathy. Stress cardiomyopathy is a response to a catecholamine surge resulting in regional microvascular dysfunction in susceptible patients. The Mayo Clinic criteria for apical ballooning syndrome involves transient hypokinesis, akinesis, or dyskinesis of the left ventricular midsegments with or without apical involvement. The regional wall motion abnormalities extend beyond a single epicardial vascular distribution. A stressful trigger is often but not always present. There are rare exceptions in which the regional wall motion abnormality is limited to a single coronary territory. Absence of obstructive coronary artery disease or angiographic evidence of acute plaque rupture is usually needed. It is possible but very rare that patients with obstructive coronary arteriosclerosis may also develop apical ballooning syndrome. We should also see new ECG abnormalities such as ST elevations and or T-wave inversions or modest elevation in cardiac troponin. There should be an absence of pheochromocytoma and myocarditis. Stress cardiomyopathy most commonly has a large region of apical akinesis and preserved contraction at the base, but there are also less common variants which have the akinetic or dyskinetic segment at the mid ventricle or base instead. Unlike most other cardiomyopathies, stress cardiomyopathy has no myocardial scarring and will have no late gadolinium enhancement on cardiac MRI. Stress cardiac MRI has an in hospital mortality of 1.2%. Rarely, stress cardiomyopathy can have complications including malignant arrhythmias, thromboembolism, LV rupture, and cardiogenic shock. 5% of stress cardiomyopathy patients will have recurrent stress cardiomyopathy in the future. If a stress cardiomyopathy has a new systolic murmur at the left upper sternal border, it could be due to new LV outflow tract obstruction resulting from hyperkinesis of the basal anterior septum. M mode through the mitral valve would show the mitral valve moving towards the LV septum during systole, that systolic anterior motion, which you usually see in HOCM. Beta blockers can be used to treat outflow tract obstruction in patients with stress cardiomyopathy by reducing contractility of the basal segments and by slowing the heart rate, which allows for more diastolic filling of the LV. Whenever there is LV outflow tract obstruction, inotropes such as dobutamine or norepinephrine should be avoided, as increasing the contractility of the base of the LV will worsen the obstruction. If something has to be used for severe hypertension, instead, phenylephrine and alpha agonists can be used to increase the MAP while also increasing LV afterload, which will decrease the outflow tract obstruction. Whenever there's LV outflow tract obstruction, you should also avoid diuretics because reducing preload will worsen the LV outflow tract obstruction. A balloon pump would decrease LV afterload and also worsen LVOT obstruction. Now, these points that we just talked about are only if stress cardiomyopathy has a new systolic murmur at the left upper sternal border that could be due to a new LV outflow tract obstruction with evidence of systolic anterior motion on echocardiogram. That's all for Takotsubo cardiomyopathy. We'll now briefly touch on myocarditis. The most common identified pathogen responsible for myocarditis has recently changed from the traditional Coxsackie or adenoviruses to parvoviruses, especially parvovirus B19 and human herpes virus 6. Serum troponin levels are commonly elevated in myocarditis in the acute phase, less than 1 month, of illness. However, a negative troponin does not exclude the diagnosis of myocarditis. CMR of myocarditis will show edema in a T2 weighted image, early gadolinium enhancement, or abnormal late gadolinium enhancement with a rim-like uptake in the septum and or subepicardial patchy distribution in the lateral walls. A definitive diagnosis of myocarditis is made when a patient presents with a clinical context compatible with myocarditis and cardiac inflammation is seen either on endomyocardial biopsy or cardiac magnetic resonance imaging. And when we talk about symptoms, this involves chest pain, syncope, palpitations, or dyspnea or fatigue. In terms of endomyocardial biopsy, it can be established with histologic criteria, such as histologic evidence of inflammatory infiltrates within the myocardium associated with myocardial generation, myocyte degeneration, and necrosis of no ischemic origin, and or immunohistochemical criteria, at least 14 leukocytes per millimeter square, including up to 4 monocytes per millimeter square, with the presence of CD3 plus positive T lymphocytes, at least 7 cells per millimeter square. Or you can also diagnose this with cardiac magnetic resonance in lieu of the invasive endomyocardial biopsy. This can be done by identifying myocardial edema, T2 base, in combination with a marker of inflammatory myocardial injury, T1 base. Plus, you should usually have cardiac troponin more than 99th percentile of the upper reference level with a rise or fall on the level on serial assessment, although negative troponin does not necessarily rule out myocarditis. Emerging diagnostic tools include microRNA analysis and 3D spatial immunophenotyping that we do not need to know about for the board exam. What do the 2021 AHA-ACC chest pain guidelines say about myocarditis imaging? In patients with acute chest pain with suspected acute myopericarditis, cardiac MRI is useful if there is diagnostic uncertainty or to determine the presence and extent of myocardial and pericardial inflammation and fibrosis. That's a class 1 indication. In patients with acute chest pain and suspected myopericarditis, TTE is effective to determine the presence of ventricular wall motion abnormalities, pericardial effusion, valvular abnormalities, or restrictive pathology, class 1. In patients with acute chest pain with suspected acute pericarditis, non-contrast or contrast cardiac CT scanning may be reasonable to determine the presence and degree of pericardial thickening, class 2B. Back out of guidelines. Features more suggestive of fulminant myocarditis as opposed to non-fulminant myocarditis include elevations in troponin and CRP, smaller LV volume with lower LVEF, and findings of multi-organ system dysfunction. Lymphocytic myocarditis is the most common form of myocarditis, but is equally represented among fulminant and non-fulminant cases. Giant cell myocarditis is disproportionately common in fulminant myocarditis. Fulminant lymphocytic myocarditis can still have a favorable prognosis if the patient survives the period of acute illness, but giant cell myocarditis has a very poor prognosis with a mean transplant-free survival of only 5.5 months, even for patients who survive the period of acute illness. Cyclosporin, azathioprine, and corticosteroids prolong the time to transplantation or death in giant cell myocarditis. Myocarditis recurs in 18% of patients. When can athletes who develop myocarditis return to competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, athletes with probable or definite myocarditis should not participate in competitive sports while active inflammation is present. This recommendation is independent of age, gender, and LV function, class 3. Before returning to competitive sports, athletes who initially present with an acute clinical syndrome consistent with myocarditis should undergo a resting echocardiogram, 24-hour Holter monitoring, and an exercise ECG no less than 3 to 6 months after the initial illness, class 1. It is reasonable that athletes resume training and completion if all of the following criteria are met, class 2A. Ventricular systolic function has returned to the normal range. Serum markers of myocardial injury, inflammation, and heart failure have normalized. Clinically relevant arrhythmias such as frequent or complex repetitive forms of ventricular or supraventricular ectopic activity are absent on Holter monitor and graded exercise ECGs. And at present, it is unresolved whether resolution of myocarditis-related LGE should be required to permit return to competitive sports. So, in other words, you should wait 3 to 6 months after myocarditis, then do echo, Holter, exercise ECG before letting athletes with myocarditis return back to sports, assuming they have no more active inflammation. And if you want to let them return to sports at any other time, you need to ensure that inflammatory markers and BNP have normalized, LVEF has returned to normal range, and there are no ventricular or supraventricular arrhythmias on Holter monitor and exercise ECG. Now, we'll end with a very brief bonus section on inherited cardiomyopathies. Most of these inherited cardiomyopathies have already been covered in other episodes, in dedicated episodes, but I wanted to take some time to go over some key word associations. Collagen 3A1 is associated with the vascular form of Ehlers-Danlos syndrome. Fibrillin 1 is the gene mutated 90% of Marfan syndrome. Notch1 gene mutation leads to bicuspid aortic valve and early aortic valve calcification. TBOX5 or TBX5 mutation on the long arm of chromosome 12 is associated with Holt-Oram syndrome, including atrial septal defect, ventricular septal defect, or hypertrophic cardiomyopathy. Galactosidase alpha mutation, or GLA, is associated with Fabry's disease. Protein kinase AMP activated non-catalytic subunit gamma 2, or PRKAG2, is associated with glycogen storage disease. LAMP2 mutation is associated with Danon disease. A loss of function mutation in KCNQ1 leads to long QT syndrome 1. A loss of function mutation in KCNH2 leads to long QT syndrome 2. SCN5A is associated with long QT syndrome type 3 if it's a gain of function mutation. If it's a loss of function mutation in SCN5A, that leads to arrhythmogenic right ventricular cardiomyopathy. The cardiovascular manifestations of Ehlers-Danlos disease are mitral valve prolapse and aortic dissection and aneurysm. The remaining cardiomyopathies have been covered in their own dedicated sections. That's all for non-compaction cardiomyopathy, Takotsubo cardiomyopathy, and myocarditis.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.